Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to Doctor Study tutorial. Today our topic is about hepatitis C virus, D virus and hepatitis E virus. I will discuss all the viva and written question for professional examination. So let's start. Here is the figure of hepatitis C virus. The characteristic of hepatitis C virus, it is RNA envelope virus, flavivirus family. It is silent killer. It is called silent killer because it has 8 weeks of incubation period. In this time, the features are not visible and patient do not know that he or she is a victim. But the virus rapidly grown up and it causes its complication. So it is called silent killer. Disease produced by it is called viral hepatitis or post-transfusion hepatitis. Genotype. Viral genome encodes a core protein to envelope glycoprotein and several non-structural protein. Hepatitis C virus has at least 6 genotypes and more than 100 subgenotypes based on difference in the genes. The genetic variation results in a hypervariable region in the envelope glycoprotein. The genetic variability is due to high mutation rate in the envelope gene and absence of proofreading function in the virion encoded RNA polymerase. Here a question is arise that hepatitis C is most dangerous virus around all hepatitis types. And why it is called so dangerous? Because it has high mutation rate in the envelope gene and absence of proofreading function. So we can't prevent it because it rapidly changes its genetic variation. That's why it is very dangerous. As a result, multiple subspecies often occur in the blood of an infected individual at the same time. This complex viral population in a host is referred as a quasi-species. Epidemiology. Hepatitis C is the most prevalent bloodborne pathogen in the USA. In USA, hepatitis C is more prevalent than the hepatitis B. Hepatitis C infection occurs throughout the world with carrier rate rising from 10 to 20%. Most important written and viva question is mode of transmission of hepatitis C virus. They are transmitted through the parenteral route, sexual contact and mother to baby. In parenteral route, blood and blood product, infected syringe or needle, infected scalpels and blade, tattooing, ear piercing. And by mother to baby, during delivery, through breastfeeding and through transplacental. Replicative cycle. The replication of the hepatitis C is uncertain because it does not grow in the cell culture. Hepatitis C may be replicated in the cytoplasm and translate their genome RNA into large polyprotein from which functional viral protein are cleaved by a virion encoded protease. Pathogenesis. Hepatitis C rich in bloodstream goes to the liver and infect the hepatocyte, can't produce cytopathic effect but destroy the cytotoxic T cell. Hepatitis C is strongly predisposed to hepatocellular carcinoma, but there is no evidence for oncogene in the viral genome or for insertion of a copy of viral genome into the DNA of the cancer cell. Cancer is caused by prolonged liver damage, rapid growth rate of hepatocyte as the cell attempt to regenerate rather than by a direct oncogenic effect of hepatitis C virus. Alcoholism greatly enhance the rate of hepatocyte carcinoma, hepatocellular carcinoma in hepatitis C virus infected individuals. Another viva and written question is clinical findings. The clinical findings of hepatitis C is asymptomatic jaundice. It is very mild, so it is called silent killer. Incubation period is 8 weeks. Adult group is affected predominantly. There are anorexia, nausea, vomiting. Fever less common, history of dark urine and pale stool. Chronic infection is also clinically silent, but histological findings is universal. 70 to 90% chronic hepatitis, 10 to 20% progress to chronic active hepatitis, cirrhosis of the liver, and hepatocellular carcinoma. Then the another important topic is complication. The complication of hepatitis C is chronic hepatitis, cirrhosis of the liver, fulminant hepatitis, hepatocellular carcinoma, and death. The very important viva question is why hepatitis C virus is dangerous than the hepatitis B virus? Because it is silent killer, mostly asymptomatic. Rate of chronicity and complication is much more. 70% develop chronic liver disease, 20 to 30% progress to cirrhosis, can also lead to liver cancer. No vaccine is available because of antigenic variation of glycoprotein, no immunoglobulin. Laboratory diagnosis: specimen, blood, serological test, antibody IgM and IgG detected by the ELISA. Here IgM is detected first, then IgG, because IgM is a primary immune response. It will detect first. Then recombinant immunoblot assay should be performed as a confirmatory test. Another one is liver function test. Normal or fluctuating serum transaminase level between 50 to 20 unit per L and increased bilirubin in the stage of cirrhosis. Detection of hepatitis C virus RNA by PCR. If the result of recombinant immunoblot assay are positive, a PCR should be done to detect the presence of viral RNA in the serum, which determines active disease. Treatment: acute hepatitis C, alpha interferon significantly decrease the number to become chronic carrier. Chronic hepatitis C, a combination of pig interferon subcutaneous and ribavirin oral. Pig interferon, alpha interferon conjugated to polyethylene glycol. Polyethylene glycol significantly enhance the half-life of the alpha interferon. Ribavirin alone has no effect on hepatitis C replication. At last, prevention. No vaccine, hyperimmune globulin are not available. No effective regimen for prophylaxis following needle stick injury. Screening of the blood organ and tissue donor. High risk behavior modification. Infection control practice in healthcare and other settings. Counsel person with high risk drug or sexual practice. Advise chronic hepatitis C virus patient to eliminate or reduce alcohol consumption to reduce the risk of hepatocellular carcinoma and cirrhosis. So this is all about hepatitis C virus. You will find hepatitis D and E in our next video. Thank you so much.